Thank you for inviting me to deliver this year's lecture in honor of Professor Olaiton Sheyowo. My name is Dr. F.D. Opeyemi Babatola. I'm a consultant anesthetist who specializes in chronic pain management. I have a special interest in neuropathic pain. I'm a product of the University of Ibadan, where I studied physiology as a first degree and subsequently then proceeded to study medicine at the University College Hospital. I also hold a PhD in physiology from the University of Wales in Cardiff. I'm a fellow of the Royal College of Anaesthetists, United Kingdom. I also hold a fellowship in the Faculty of Pain Medicine in the United Kingdom. I have been a consultant in pain management for about 27 years. I have officially retired and have now been classified as an old age pensioner. I, however, continue to practice in my hospital. I have been advised today that the audience spans quite a wide range of practitioners, hence want to make it relevant. I will start by asking us, what is the definition of pain? In 1979, the International Association for the Study of Pain defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. However, in 2020, about 40 years later, it redefined pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. That is the current definition. It is not much different from the previous one, but it's now better defined. I want us to pay attention to certain words in this definition. The first one is unpleasant. We all recognize pain as being unpleasant, unless, of course, you're a masochist. Sensory and emotional. It is an experience, sensory and emotional. Those are keywords that will guide us into proper management of chronic pain, whether neuropathic or inflammatory. But precisely with neuropathic pain, because it's usually a prolonged, excruciating situation. What is pain? Pain could be inflammatory or neuropathic or both, depending on the cause of the sensation. What is neuropathic pain? Neuropathic pain is often the result of structural damage to nerves or a malfunctioning of the nervous system. The damage to the nerves usually results in a change in the functionality of the nerves, both at the site of the injury and in the adjacent areas. The pain may mimic the distribution of the particular nerve involved. Patients often describe neuropathic pain in terms of being a sharp, shooting, and or burning sensation. It could be rated as severe, excruciating, and unrelenting. It may be continuous or intermittent. Sometimes, but not often, the pain may go away on its own, but most of the time it is chronic and persistent. An example is sciatic nerve. It could occasionally disappear and then it reappears, and the patient then presents and describes it as having had the pain before, it went away and then it's back again. Neuropathic pain could be as a result of various situations. Some of the causes include trauma, for example, road traffic accident in which a limb may subsequently be severed, or as a result of gangrenous situations in the extremities leading to amputation. It could also be due to chronic alcoholism, for example, pancreatitis. It could be due to chemotherapy or radiotherapy. It could also be a complication of the consequences of diabetes mellitus. Isolated nerve damage will also be responsible for neuropathic pain, for example, facial nerve neuralgia, trigeminal neuralgia, and posthepatic neuralgia. You could also have pain in HIV infection or AIDS. In malignancy situations, for example, in multiple myeloma, you could get neuropathic pain. Neuropathic pain could also common in multiple sclerosis, as well as in neural compression, for example, herniated discs in the back, foraminal stenosis in the spine, and cauda equina. You could also have post-surgical pain as a result of spinal surgery, or even simple things like aneuropathy. You could have chronic neuropathic pain in syphilis. Usually, the patients present with a long-standing history of chronic pain. They will have presented that the pain has been there for quite some time, and they may have given you a history of some degree of trauma or accident in the past, which is related to this pain. They would describe the sensation as a sharp shooting and burning sensation. In some cases, they may describe tingling sensation in specific areas, and this may be described even as pins and needles. There may be numbness. There may also be changes in temperature associated with the pain. The sensation described may follow a particular distribution. To make a good diagnosis of chronic neuropathic pain, you will need to have a good history taken, and you will need to find out the onset of the pain, when and how long it has been. You also need to find out the circumstances that surrounded the origin or the onset of the pain. The characteristics of the sensation itself could be a giveaway. You may also need to find out the factors that may or may not provide relief from the pain. The descriptive words used by the patient may guide you towards making a diagnosis. In other words, those words that sharp, shooting, burning, excruciating pain sensation are usually a guide towards what the situation is. A thorough examination of the patient, where possible, may confirm in most cases the diagnosis. Description of the pain is always a giveaway. Its occurrences, its timing, as well as the triggers that may give you a good example, may be indicative of the diagnosis of the pain. Where necessary, some tests may be needed to be carried out, and this again may confirm the nature of the pain. For example, you may need to do nerve conduction tests, or even simple sensory testing in the clinic may give you a good indication. And this is a situation in which you may find that part of the problem the patient has lies in the damage to not just the pain fibers, but also to touch fibers, in which case the patient complains of numbness, even though he says that area is painful. Historically, chronic neuropathic pain had not been well managed. It has always been poorly managed, and this has been due to a lack of understanding of the way the nervous system functions. When I was a medical student, as well as when I was a physiology student, we were told that the nervous system was a hardwired system. But in the last 3 decades, it has become very apparent that there is a plasticity in the way the nervous system behaves. That understanding has contributed to some extent in our understanding of neuropathic pain. There has been development of various experimental models, which has now enhanced the understanding, and hence the management of neuropathic pain has improved. In clinical practice, the more common presentations that we have include chronic low back pain, which may present as back pain and or sciatica, chronic neck pain, cervicalgia, diabetic neuropathy, posthepatic neuralgia, trigeminal neuralgia, radiotherapy and chemotherapy-induced pain, phantom pain and sensation, post-surgical pain, complex regional pain syndrome types 1 and 2, chronic sickle cell pain, and chronic central pain, which may be as a result of a stroke. Let us, as an example, consider phantom pain. In the 19th century and up to the middle of the 20th century, most people did not accept that this condition existed. Most patients were told it was in their minds. The phantom pain generally occurs following amputation of a limb. This may be due to, for example, gangrene in the foot or in the hand, or it could be due to road traffic accident in which the limb had to be amputated to save the patient's life. If you consider the lower limb, the leg is supplied by both sciatic and femoral nerves, mainly. If you amputate a limb below the knee, you will have taken out all the tissues below the knee. However, you will have left the cut end of the nerves in the knee and above the knee. Healing takes place, but you have not taken out the nerves that go into the spine. The strands of femoral nerve and sciatic nerve have been cut at the knee, but they still maintain their neural connections at the spinal level. When healing takes place, there may be scar tissue forming around the tips of the cut ends of the nerve. These may form neuroma, which constantly irritate the cut ends of the nerve. Since those nerves were programmed to send information from the leg to the brain translates any information as coming in from the foot or the leg. Hence, the patient describes the sensation as if he or she still has a leg intact. If the pain fibers are the ones being irritated, they describe pain as coming from the foot, but they know that there is no foot there, and that's phantom pain. So, how do you manage pain in a foot or a leg that doesn't exist? Another example is chronic low back pain or chronic neck pain. With low back pain, you find that it is a condition that is very common in the developed countries. About 70% of my workload in my practice consists of chronic spinal pain, which mainly consists of chronic low back pain radiating into the legs and chronic neck pain radiating into the upper limbs. It reflects the kind of population that we deal with. Chronic neck pain and chronic back pain tends to occur in populations where they mostly have sedentary lifestyles. It is probably one of the most common types of pain that most pain specialists will come across in their practice. It is also similar in that situation with neck pain. The pain may or may not radiate into the limbs. If it was neck pain, it may radiate into the scalp and into the upper limbs. Patients may then describe burning sensation and or tingling sensation in the limbs, and as it progresses, they may present with heaviness and a weakness in the affected limbs. Chronic low back pain may radiate into the lower limbs. This is usually as a result of degenerative changes in the spinal structure. This may be due to disc bulges pressing on nerves in the lateral foramina, or it may be due to arthritic changes in the facet joints in the posterior aspects of the spine. It could also be due to a combination of both. In the first instance, it will be due to pressure on the bulging disc on the sensory fibers. The initial damage is to the pain fibers. They are the smallest fibers and respond quickly to damage. Touch, pressure, and temperature fibers come next, and this is usually why the pain comes in on before the sensation of numbness and coldness. How do we manage neuropathic pain? The management of neuropathic pain is multidisciplinary and it is multimodal if it is going to be successful. It requires the input and cooperation from various members of a dedicated pain team. Essentially, a pain team will consist of at least the following individuals: a medical personnel, a physician possibly, most of the time an anesthetist, a nursing personnel, a physical therapist, a physiotherapist, a psychologist, and also possibly a pharmacist. In some situations, you may have an occupational therapist being involved. Let us go back to our definition of pain. Remember, we talked about a sensory and emotional experience. In managing pain, neuropathic pain, we have to attend to not only the sensory aspect, but we also have to deal with the emotional aspect. And this is because chronic neuropathic pain usually lasts for a long time. And generally, by the time they present, they have been in a lot of difficulties. Many patients will have lost their jobs. Many of them will have had problems with family stress and distress, as a result of which there is a certain amount of mental health distress involved in the pathogenesis of this type of pain. This is why the use of a dedicated pain team is very essential. The recovery and maintenance of functionality is very important in the successful management of chronic neuropathic pain. There is no single type of treatment that will adequately deal with neuropathic pain. Note that in most cases, you may never get a cure. Hence, the emphasis is on rehabilitation and attaining an improved quality of life. It is the recovery of functionality and its maintenance that is very important. The onset of chronic neuropathic pain can be very demoralizing. Patients become very anxious, depressed, withdrawn, and sometimes socially aggressive. They may lose their jobs and hence unable to meet their financial obligations. This may lead to family stress and distress. It may lead to separation and ultimately divorce. The mental health status of the patient is thus very important. The psychological intervention is very important, hence the role of the pain psychologist in the management of chronic neuropathic pain. In my clinical practice, one of the first considerations is an assessment of the mental health status of the presenting individual. It is important to find out how the mental health situation is. We use the hospital anxiety and depression questionnaire for the initial psychological assessment. It is designed to indicate the level of anxiety and the level of depression that may exist in non-psychotic patients. In other words, patients who have no psychiatric illness. And this is why it is suitable for patients presenting in the chronic pain clinic, because most of them have not got to the point where they have psychiatric illnesses. The questionnaire, when scored, can give an idea of the level of anxiety and or depression that the individual has. It is one of the many different psychological tools that we use to assess the patients and their first consultation. It is a self-rating scale developed to assess psychological distress in non-psychiatric patients. Another is Pain Detect. There is a wide variety of these assessment tools, and some can be adapted to local circumstances. We tend to use the hospital anxiety and depression scores because it is simple, non-confusing, and it appears to suit our local population. Permit me again to go back onto physical therapy. The physiotherapist is an essential member of the team. Physical therapy is essential. A painful limb is difficult to exercise, but it has to be done if we are going to achieve any degree of relief in this neuropathic pain management. Gentle and graded exercises at the beginning is quite important. The aim is to maintain functionality, and that is important. Failure to achieve this may lead to atrophy of muscle groups. The physiotherapist, therefore, is an essential member of the pain team. Swimming can be a very good modality for exercising all the groups of muscles in the body. Physiotherapists also use acupuncture, TENS machine, and these are some of the other facilities that physiotherapists employ in the management of chronic pain. The specialist nurse belongs to a group of practitioners that are usually overlooked in the provision of facilities for managing chronic pain. I find in my practice that because of their background, in which they tend to have a one-to-one relationship with the patients, they're able to relate to these patients at a level that sometimes other practitioners may not be able to achieve. It is even more effective if they come from within the community itself. They're able to explain and translate the methods of management as well as the procedures that we offer at the patient level. Many of these are trained to perform some procedures, thus freeing the physicians to do more complex work in the provision of pain management. One of our nurses used to provide the acupuncture clinic, in which she did both needle acupuncture and laser acupuncture. She also provided the electroacupuncture facility. Medications have in the past been the mainstay of management of chronic neuropathic pain and hence the poor results. For many years we had relied on medications, but unfortunately there were not many medications that can adequately give relief in neuropathic pain without causing unacceptable side effects. As a result, up until the 1990s, the relief obtained from medications have been minimal, except in conditions such as trigeminal neuralgia. Prior to 1990, the main pharmacological application had been the antidepressants, with amitriptyline being the more commonly used and prescribed drug. In the last 30 years, new medications in the anticonvulsant and antidepressant groups have emerged. These have contributed to the provision of better management in the treatment or management of chronic neuropathic pain. Opiates are not particularly effective in managing neuropathic pain, except when there is some degree of inflammatory pain involved. Simple analgesics such as paracetamol also and non-steroidal anti-inflammatory drugs are not very effective, and they tend to be the ones that the family doctor will have tried the patient on prior to the presentation in the chronic pain clinic. Anticonvulsants. The introduction of gabapentin in the late 1990s has brought about a marked improvement in the management of chronic neuropathic pain. Anticonvulsants are known to have effect on chronic neuropathic pain. However, monotherapy, while improving the management, has been found to be not as good as combination therapy. In combination therapy, anticonvulsants are combined with antidepressants, and the combination has yielded better results. Pregabalin is another anticonvulsant that has been introduced into the management of pain in the last 20 years. Others that have been used include topiramate, lamotrigine, and in the case of trigeminal neuralgia, carbamazepine. The latter has been available for a long time. I tend to use the anticonvulsants, the antidepressants, in order to reduce intensity of the pain. Gabapentin is one of those anticonvulsants that I tend to use frequently. It is unique in its dosage, and if the practitioner does not understand this, it may give the impression that gabapentin is not an effective drug in the management of chronic neuropathic pain. It is a unique drug. However, the dosages are not specific. Each patient must find out what dosage is effective for himself or herself. I have patients who cannot take more than 200 milligrams of gabapentin in a day. Anything beyond that practically knocks them out because it can make you very drowsy. In the same vein, I have a gentleman who is 87 years old and is on 4,800 milligrams of gabapentin per day. That is 1,200 milligrams 4 times daily. That gives him good relief and is able to cope with day-to-day living. It therefore shows that each individual must find out the dosage that will suit him or her and give him adequate relief. I tend to use the following regime. The first week I start with 100 milligrams 3 times daily. The second week I go on to 200 milligrams 3 times daily. The third week I go on to 300 milligrams 3 times daily. And the fourth week I use 400 milligrams 3 times daily. The fifth week 400 milligrams 4 times daily. In the 6th week, 600 milligrams 4 times daily. I titrate up to 2,400 milligrams per day. If during the titration, the patient does not get relief, but has no side effect, then I continue with the titration up to 2,400 milligrams. If it does not give adequate relief, or there is side effects, I then trial pregabalin instead. I also add antidepressants along with the gabapentin. I use amitriptyline, and I can go as high a dose as 75 milligrams at night. I use citalopram also, up to 40 milligrams at night. I also use duloxetine. I tend to favor duloxetine because it is actually licensed for pain management in diabetic neuropathy. So it is specific in that respect, and therefore it does help when combined with one of the other anticonvulsants. Antidepressants. Antidepressants have a role to play in the management of chronic neuropathic pain. Severe pain that is unrelenting can cause depression. It may also cause anxiety because the patient feels that the doctor has not been able to identify his or her problem, and that is why they could not find any reason or any way to manage the pain. A few patients have inquired when they present in the pain clinic if they have cancer. This unfortunate thought continues to be entertained in their minds, and the patient becomes more anxious, more depressed, and again the pain levels rise. This unfortunate cycle needs to be broken. Antidepressants help in this direction. Some antidepressants actually have been shown to provide analgesia. An example is duloxetine in the management of diabetic neuropathy. Duloxetine is one of the licensed and recommended medication for use in diabetic neuropathy, which is a neuropathic pain. Opioids are not generally very effective in the management of pure neuropathic pain. They seem to be of help when there is a component of inflammatory pain. The patients tend to report that they have some relief, but the terminology generally is that the medication takes the edge off the pain. It will appear that opioids do have some help when there is a component of inflammatory pain within the pain sensation. This, for example, can exist when there is a malignancy. If the malignant tissue erodes into an area where there is a nerve passing through, and it causes both erosion and in the tissues around the place, as well as damaging the nerve. You then have two components there. You have an inflammatory pain due to the cancer, and you also have a neuropathic pain due to the nerve being damaged. Morphine or opioids generally will help in reducing the pain due to the erosion in the tissues around the area, but do not have much effect on the damage done to the nerve, which is the neuropathic pain. The danger in increasing the dosage of opioids upwards is in the development of tolerance and the acquisition of opioid-induced hyperalgesia. These conditions are difficult to manage. I have seen patients in the clinic who have turned up taking 200 milligrams of morphine sulfate a day, And I've seen others also on about 500 milligrams of morphine a day. This is not a useful way of managing neuropathic pain. The patients will eventually develop tolerance as well as opioid-induced hyperalgesia. These are conditions difficult to treat. Prolonged administration of large amounts of opioids also may result in reduced immune function, leading to frequent infections, such as urinary tract infections, and it may also lead to hyperfunction of the hormonal system. Interventional procedures. Within the pharmacological interventions lie the invasive interventions. Most consist of steroid injections in various forms depending on the diagnosis and what is thought to be responsible for the pain. These do not provide a cure either. They only provide attempts which provide reduction in the intensity of the pain so that the patient can be more active and functional. It is important at this stage to stress exercise. When the blocks or when the injections are done, the patient may obtain good relief. This creates an analgesic window during which the patient can be more active and therefore can recondition the muscles which may have become deconditioned during the pain situation. Steroid injections are more effective when there is a component of inflammatory pain. These injections include shoulder injections, knee pain injections, elbow injections, wrist injections, hip injections, as well as injections into the knee joint. Others include facet joint injections, epidural injections, either lumbar, cervical, or thoracic, and this may help in the relief of pain in canal stenosis. They may also perform nerve root blocks. All these injections basically provide a temporary relief, which allows the patient to be more functional and therefore reduce the pain. A good proportion of my practice consists of back pain, and this could be neck pain, thoracic pain, or low back pain. However, the majority is low back pain. In managing this pain, spinal injections may be deployed. These include epidural injections into the lumbar spine. It may include nerve root blocks as well as transforaminal epidural injections. Generally, these injections are short-lived, but they provide a respite. Facet joint injections may be done also at cervical, thoracic, and lumbar levels. The main principle is to provide an analgesic window during which the patient obtains some relief. During that period, the patient should be referred to physiotherapy and should be encouraged to be more active. More effective is nerve ablation. It is commonly done in the back and when successful provides a longer period of relief. The principle is to ablate the nerve related to the pain. In low back pain, this is the lumbar facet nerve. A radiofrequency probe or needle is applied to the facet nerve prior to its entry into the joint. Thermal energy is then applied at about 80 degrees to 90 degrees Celsius for about 90 seconds. This disrupts the nerve and breaks the pain cycle. It takes more than a year on the average for it to regrow and bring back pain. The procedure can be repeated. It can also be applied to other nerves such as the suprascapular nerve and genicular nerves in the knee joint. There are other forms of invasive therapies, and these include spinal cord stimulation, implanted devices for continuous intrathecal infusion of analgesics, and deep brain stimulation. In spinal cord stimulation, an electronic device is implanted and controlled via a remote control unit which the patient handles. The spinal cord is stimulated to reduce the transmission of pain sensation. It is usually done in intractable back pain when all other interventions have failed and the patient is in excruciating pain. An example is a failed back syndrome. It is also used in the management of severe diabetic neuropathy, which has not responded to any other therapy. Deep brain stimulation. This is also available in a few highly specialized units, and it is to provide pain relief. The skills required for providing this and the maintaining of his surveillance is limited, and hence it is not widely available. Chronic neuropathic pain has been difficult to manage. It is obvious that medications, either singly or in combination, may not provide the relief needed. There may be side effects that stops the effectiveness of the medications. Anticonvulsants and antidepressants have gone a long way in improving the management of chronic neuropathic pain. It has also become apparent that attempts to improve the mental health status of the patient contributes in a large measure to improve management of chronic neuropathic pain. Being active and maintaining functionality, especially through exercise, remain one of the keys to better management of neuropathic pain. Invasive therapies have not really lived up to the expectations, although they have provided an analgesic window that has allowed some respite from the pain. The establishment of pain teams is essential to improving the management of chronic neuropathic pain. As more practitioners are identified and trained, hopefully there will be more facilities established nearer the patient. The problem on the ground now is not only the paucity of staff training facilities, but also the inability to retain the few that have been trained. It is hoped that a possible improvement in the political, economic, and security environment in the country will contribute via the provision of staff and facilities to improving the management of chronic neuropathic pain in the country. It is also hoped that further research, especially locally, will contribute in a large measure to finding solutions close to home that may help in resolving the problem. Thank you.